Please start, sir. We are live.
Yeah.
Good
Good
evening,
evening again.
everyone.
Okay.
Okay, sir, you can
No,
proceed.
you start, then I will.
Okay, sir. Good evening, everyone. I welcome you all for today's webinar on clinical updates in lung, breast, and GI and GU hematological malignancy. For the welcome and introductory note, I would like to invite Dr. Abhishek Bansal, sir. Sir is consultant medical oncologist, SSB Hospital, Faridabad. Over to you, sir.
Good evening again, and I welcome all the faculty and attendees who are present here for this virtual conference. Hope you had a wonderful learning for the day one session of oncology updates. And yesterday's session was mainly focused on the lungs. And so, coming to today's day two session of oncology updates, this will be more on the breast and hematology and some part of GI update. So, without wasting much time, I will start with the first session and I will hand over the mic to organizers. So, organizers, you can welcome our first speaker, please.
For the next session, I would like to invite none other than Dr. Sandeep sir. Dr. Sandeep sir is consultant medical oncologist in National Institute of Medical Science in Jaipur. And this session is sponsored by Pfizer. Over to you, sir.
Good evening, all. My talk is on the management of EGFR positive non-small cell lung carcinoma, focusing basically on the second generation dacomitinib rule and how it is influencing the lung cancer patients. So, in ranking of Asia in terms of estimated number of new lung cancer in 2020 in all ages and both sexes, India was fourth in all these countries. So 72,000 new patients of cancer of both sexes, male and female case, were diagnosed in 2020. And the EGFR treatment landscape has changed a lot since the 2000 when the first generation TKI, gefitinib and erlotinib started changing the treatment behavior of the EGFR positive patients, and subsequently when the second generation TKI like afatinib and dacomitinib, and subsequently the third generation TKI osimertinib has dramatically changed the lung carcinoma patients' survival. The identification of these activating mutations in EGFR, like the deletion of exon 19 and point mutation in exon 21 L885R, is important because we have a molecularly guided precision therapy available for management of these malignancy. And I'm going to discuss the Archer 1050 trial in detail. This was the trial which has given a paradigm shift in the EGFR positive mutated NSCLC patients. In this trial, dacomitinib was compared with gefitinib as first-line treatment of patients who are EGFR positive. It was a phase 3 randomized trial, and the key eligibility criteria were patients having advanced non-small cell lung cancer, having a measurable metastatic disease by the RECIST criteria version 1.1, who have not been received any systemic treatment previously, having no CNS metastasis, and having no prior EGFR TKI exposure, and the physical fitness level of 0 to 1 were randomized in a 1:1 fashion among dacomitinib 45 mg daily, and the other arm was gefitinib 250 mg daily. And the primary endpoint was the progression-free survival as assessed by the blinded independent review committee in the intention to treat population. And the secondary endpoints were the progression-free survival, which was investigator assessed, overall response rate, and duration of response, time to treatment failure. Stratification factors were race, including Asian versus non-Asian, and EGFR mutation type, whether it is exon 19 deletion or it's a point mutation in the L858R region. And what we have found out that when we have used dacomitinib as the experimental therapy, the total number of events were significantly low in the dacomitinib arm as compared to the gefitinib arm. And median progression-free survival was significantly better in the dacomitinib arm versus the first generation gefitinib arm. As we can see in this graph, the event were only 136 in the dacomitinib arm and it was 179 in the gefitinib arm. PFS, whether assessed by the independent review committee or by the investigator assessment, both were in favor of the dacomitinib. In this forest plot, as we can see, the dacomitinib when compared to gefitinib across the spectrum of patients, whether they are below 65 year, more than 65 year, male patient, female patient, Asian, non-Asian, never smoker or current smoker, irrespective of the EGFR mutated patients, they all get benefited. Although the Asian patients benefited more rather than the non-Asian patients. When we talk about the progression-free survival with respect to the EGFR mutation, exon 19 deletion and exon 21 L855 are substitution mutation. Both of these patients were having additional benefit with the dacomitinib. The median progression-free survival was 16.5 months in the dacomitinib arm versus gefitinib arm showed a PFS of 9.2 months. Similarly, in the exon 21 mutation arm, dacomitinib has shown a progression-free survival of 12.3 months, and gefitinib has shown the PFS of 9.8 months. And as we can see in this table, although the overall response rate, which include the CR rate, PR rate, and stable disease, were quite similar in both the arms, but it was the depth of remission and the duration of response, which was significantly longer in the dacomitinib arm as compared to the gefitinib arm. So, as we have seen, the objective response rate were not markedly different in the dacomitinib arm and the gefitinib arm, but as we can see in this table again, the number of events were significantly low in the dacomitinib arm. It was 54 in the dacomitinib arm and it was 78 in the gefitinib arm when I am talking about the exon 19 deletion patients. And similarly, in the exon 21 L855 or substitution mutation, the number of events were 43 in the dacomitinib, and the gefitinib arm was having 59 events. So that means dacomitinib has the significantly more tumor control and depth of remission. Similarly, when I talk about the adverse events, although this table showed that the dacomitinib has plenty of side effects in the terms of diarrhea, paronychia, stomatitis, dermatitis, but majority of these side effects were grade 1 and grade 2. And the patients having grade 3 or grade 4 toxicities, the proportion of these patients was significantly low. And most of these toxicity were quite manageable either by the supportive care or by a temporary dose reduction. Few patients does require permanent drug decrease in dose. So what is the dose modification? The first dose reduction in the dacomitinib arm was 30 mg per day, and the second dose reduction was the 15 mg per day. And it was 25 in the gefitinib arm, it was 250 mg every 2 days. So what was the improvement in OS with dacomitinib? The improvement in OS with dacomitinib remains statistically significant, and as we can see in this graph, the median overall survival was 34 months in the dacomitinib arm, and it was 27 months in the gefitinib arm. And the curve still continued to get separated even after the completion of trial. And in this updated overall survival analysis of Archer 1050, after an extended follow-up of study results, dacomitinib continued to show benefit across the spectrum of patients, irrespective of the smoking status, EGFR mutation status, and race status. And when I talk about the overall survival based on the EGFR mutation status type from extended follow-up, patients having EGFR exon 19 deletion, they do get benefited. The median overall survival in these patients was 36 months versus 31 months in the Jefferson arm. And in the exon 21 patients, it was 32.5 months versus 23 months in the Jefferson arm. So what is the effect of dose modification on the safety and efficacy of dacometinib for the EGFR mutation positive non-small cell lung cancer patients? So this was very interesting. In Archer 1050, the starting dose of dacometinib for all patients, it was 45 mg daily, with a maximum of 2 dose level reduction were permitted. First dose reduction was 30 mg. It happened in almost 38% patients. And second dose reduction of 15 mg daily happened in 28% of patients. Most of these reduction happened in the initial 13 weeks, and the after that, the later 12 weeks, the second dose reduction happened. Skin toxicities, diarrhea, and paranoia were the major toxicity. Because of these toxicity, dose reduction happened. Progression-free survival for dacometinib in all patients and those with dose reduction. Patients receiving dacometinib who was having a dose reduction of 30 mg and 15 mg. Actually, the event rate was low in these patients, and we compare to the whole patient population. So the patient who has received 15 mg, 30 mg reduced dose, the median progression-free survival was 16.6 months in these patient population, as compared to the whole patient population, in which median PFS was 14.7 months. So this was something we are really interested to know, because many times in clinical practice, there is a fear among mind of physicians that when I am decreasing the dose, am I not compromising with the efficacy? Am I not compromising the patient progression-free survival or overall survival? So it gives me a confidence that I am not compromising the patient life. And what about Asian subgroup? Safety and efficacy of dacometinib for the EGFR positive and SCLC in the subgroup of Asian patients from Archer 1050. The eligibility criteria were same. Patients having advanced non-small cell lung cancer who has not received any previous systemic therapy, having no CNS metastasis, and who have not received any EGFR TKI, with a fitness level of 0 to 1, were randomized in 1:1 fashion in the dacometinib experimental arm, and the standard arm was a gefitinib. PFS, the primary endpoint was the PFS, as assessed by the independent review committee, and the stratification factors were race and EGFR mutation type. And as we can see in this graph, progression-free survival was statistically significantly improved with dacometinib compared with gefitinib when it is compared in the Asian patients. So in the Asian patients, the median, the number of events were quite low, 97. And in the when Asian patient has received gefitinib, the number of events were 140. So that gives that against favor the use of dacometinib in Asian patients. The progression-free survival is 16.5 months in these patients, in these Asian patients, and 9.3 months when I use gefitinib in these Asian patients. Again, in the and in this forest plot, again, Asian patients across the spectrum, whether they are more than or less than 65 years of age, whether they are current smoker or ex-smoker, irrespective of the EGFR mutation status, these patients, they get benefited with the dacometinib rather than the gefitinib. Best overall response in Asian and overall ITT population. Again, the response rate were not markedly different in the Asian patient and in the whole population. Time to treatment failure were significantly longer in the Asian population when they get treated with the dacometinib in the first line therapy as compared to the gefitinib. So Asian patient receiving documentary in the first line, they have a number of events 121 only as compared to 155 when they get treated with the Jeftinib. And time to treatment failure was 13 months in the documentary arm as compared to 9 months in the Jeftinib arm. So again, progression-free survival by the independent review committee review in Asian patients as per mutation subgroup. In the exon 19 deletion, again, as expected, documentary has shown decrease in events. It was 56 only. Progression-free survival 16.6 months as compared to 9 months in the Jefferini arm. Exon 21 patients, again, events were low as expected, 41 only with the documentary and 60 when treated with Jefferini. The PFS was 16 months in the documentary patients and 11 months in Asian patients receiving Jefferini in the first line. And the overall survival in the Asian subgroup and the non-Asian subgroup patients. The Asian patients receiving documentary in the first line, they have a number of deaths only 95 as compared to 115 in the Jefferini arm. Median overall survival was 37 months in the documentary arm and it was 29 months in the Jefferini arm. In the non-Asian population, when we use documentary in the first line, the number of deaths among documentary and Jefferini is almost equal, and overall survival is 29 months, better than the 20.6 months in the Jefferini arm. Although these are subgroup analysis, we can't 100% rely on that, but they definitely give information that the biology of Asian patient and non-Asian patients is not the same. And the updated overall survival in Asian patients with EGFR exon 19 deletion and exon 21 substitution mutation. Patients of exon 19 deletion, again, the number of events were less in the documentary arm, and the median progression-free survival was better as compared to the Jefferini. It was 37.7 months versus 36 months in the Jefferini arm. In the EGFR L858R substitution mutation, the number of the deaths were less in the documentary arm. It was 43 as compared to 54 in the Jefferini arm. And the overall survival was 36.5 months versus 25.6 months in the Jefferini arm, as expected, because first generation TKI doesn't have so much of tumor control in these patients who are having exon 21 mutation. And one Indian study about this, documentary in Indian patients, study from the Tata Medical Center, Mumbai. The objective of this study was to gain insight from the real-world experience of documentary in patients with brain metastasis and uncommon EGFR mutation. And it was a single center study, was a retrospective study done on EGFR mutated advanced NSCLC patients from July 19 to February 23. Endpoint was to assess the clinical pathological feature and treatment details and toxicity and treatment outcome to be recorded of these patients. So what was the real world experience? The total number of patients treated was 111. Most of these patients in the median age was 62 years. Performance status, as expected, it was 1 or 2 in these patients. Median follow-up was 19 months. And intracranial responses was CR in 2 patients, partial response in 18 months, that showed the intracranial effectiveness of the documentary, that it does penetrate the blood-brain barrier. And the efficacy data, the median progression-free survival was 21.5 months in patients who has received a documentary, and median overall survival was 31 months. Safety profile, when I talk about safety profile, 73% of patients had any grade of toxicity, 47% of any grade patients has developed grade 2 or grade 3 toxicity. In total, 23 patients required dose modification. And as we can see in this table, as we can see the hazard ratio, the dacomitinib has 3 times better response in the brain metastasis as compared to the patients when they are treated with the other first generation TKI. Exon 21 patients behave 1.6 times better when they are treated with the docomitinib as compared to first generation TKI. Dose reduction with 30 mg doesn't compromise the efficacy, as we can see the hazard ratio here. And it was concluded that docomitinib is active in patients having brain metastasis who are having uncommon EGFR mutation, and in patients with poor PS, because in those patients 45 mg will not be tolerable, and 30 mg to start with 30 mg is a very good option among these patients. So brain metastasis, and in the this is data from the Archer 1050. The number of patient new lesions in patients receiving docomitinib was significantly less. It was only 6 when it was 18 in the gefitinib arm. So it has a decent intracranial control. So apart from that, liver metastasis, bone metastasis, and other metastasis patients, the new lesion, the appearance of new lesion is almost the same. But my worry about the intracranial control, it is definitely better with the docomitinib. Another trial is ATORG 003, when docomitinib with or without dose titration. It was a multinational, multi-center, single-arm, open-label phase 2 clinical trial in which advanced 3B and 4 recurrent EGFR mutated patients were included. These subjects with asymptomatic CNS metastasis were eligible, and they have received docomitinib 30 mg only. We can escalate to 45 mg if there is no toxicity, and further dose reduction was permitted as per the adverse effect profile. Primary endpoint was the progression-free survival at 12 months, and the secondary endpoints was overall survival, overall response rate, and time to treatment failure, and intracranial objective response rate. Again, as expected, intracranial activity documented in treatment-naive advanced EGFR mutated patients, it was better in the documented arm. The intracranial overall response rate was 67%. Median progression-free survival was not reached. Median investigator assessed duration response was not reached. And it was concluded again that documentin has significant intracranial activity with observed durable responses in advanced EGFR mutated NSCLC patients with CNS metastasis. So this again, there is a contention about the sequencing of the first, second, and third generation TKIs. So currently, more or less, the treatment paradigm is the current landscape is like erlotinib or gefitinib or afatinib in the first line. And during progression, if there is a T790 mutation, osimertinib, or if they are negative, chemotherapy. And in third line, we don't have any clear-cut option. And definitely with the data of Archer 1050 and ATORG trial are guiding us that maybe the future landscape will be like this. So documenting will come in the first line, and eventually when these patients get progressed, if they are having T790 mutation, obviously osimertinib will be used. So the key messages, the ATORG 003 trial has indicated a significant intracranial activity with docomitinib. Docomitinib was superior to gefitinib with respect to PFS and duration of response. Response rate was high and durable with docomitinib in Indian patients with brain metastasis and uncommon EGFR mutation. Patient treated with docomitinib showed greater overall improvement in patient-reported measures of key disease-associated symptoms as compared with gefitinib. An Archer 1050 trial showed significant PFS and OS benefit of docomitinib, and in the 66% of patients who had dose adjustment, the efficacy was maintained. Thank you.
Such a nice talk, sir.
Thank you.
For the next talk, I would like to invite Dr. Abhishek Bansal, sir. The next section is also sponsored by Pfizer. Sir is uh, consultant medical oncology, SSB Hospital, Faridabad. Over to you, Abhishek, sir.
Can you put on the slides, please?
Sure, sir. Rishabh, kindly share the slides.
So, good evening, everyone. Again, I'm going to speak on the topic treatment benefit of CDK4/6 inhibitors with hormone receptor positive, HER2 negative advanced breast cancer in clinical trials and the real world scenario. Next slide. Next slide. So, coming to the CDK4/6 inhibitors, which extend PFS and OS in randomized controlled trials in patients with hormone receptor positive, HER2 negative metastatic breast cancer. You can see the like the this comparison. The its hazard ratio is significantly shifted towards the left, and it favors the CDK4/6 inhibitors both in PFS and OS. Next slide. So coming to the action of activity, you can see how these are how they act. The various CDK4/6 inhibitors, including first generation of palbociclib and the second and third are ribo and abima, and greatest potency being the abima of abemaciclib. Next slide. OS with first line palbociclib plus letrozole versus placebo plus letrozole in patients with hormone receptor positive, HER2 negative advanced breast cancer. Analysis from Paloma 2 trial. Next slide. Palbociclib was the first CDK4/6 inhibitor approved as treatment for this type subgroup of patients from results from Paloma 1, and Paloma 2 was a phase 3 randomized double-blind study demonstrated significant and clinical meaningful improvement in the endpoint of PFS that so confirming the findings of Paloma 1. After a median follow-up of 23 months, median PFS was 24.8 months with palbociclib and letrozole versus the placebo of letrozole, and hazard ratio was significant. And at the time of final PFS analysis, OS was not mature. Final OS analysis was performed after required events were reached with median follow-up of 90 months. Next slide. Results of the Paloma 2 study design. Eligibility criteria: postmenopausal women with ER positive or hormone positive, HER2 negative advanced breast cancer, no prior treatment for advanced disease, ECOG PS 0 to 2, randomized with palbociclib and letrozole versus letrozole. Primary endpoint was PFS. Secondary endpoint was OS, response rate, safety, biomarkers. Stratification factors were disease site, visceral, non-visceral, disease-free interval, de novo, metastatic, less than 12 months of recurrence, which could be called endocrine resistant, or greater than 12 months, which could be called endocrine sensitive, and prior neo or adjuvant hormonal therapy. Next slide. Next slide. Next slide. So you can see that in the PFS, the graphs are clearly separated, and the PFS for the palbociclib with letrozole is better than the plain placebo with letrozole arm, and you can see ADAR ratio is 0.56, and the PFS is 27.6 months versus the 14.5 months of the letrozole arm. Next slide. This is coming to the baseline characteristics of the patients. The age, the median age of were similar, the ECOG performance status, and basically disease side, the disease-free interval, and endocrine therapy and prior systemic treatment given or not. Next slide. So Paloma 2 survival disposition. In this, you can see the deaths were 62% with palbociclib and letrozole, and 25% were alive, and missing data is around 13%. And in the placebo arm, missing data is 21%, and death is 60%, and patients alive are 19%. 66% due to consent withdrawn, 34% due to loss to follow-up on the reason. Next slide. The overall survival. So comparing the overall survival, the hazard ratio is 0.9. The p-value is also not significant when compared with the palbociclib and letrozole versus the letrozole arm. This is the median follow-up after the 90 months. So the overall survival was not significant. Next slide. So overall survival in subgroups, the ECOG 0 subgroup has maximum disproportionate missing data between the two arms. Letrozole arm performance is unprecedented. Next slide. Subgroups with least disproportionate missing data can be shown here. Next slide. So post hoc analysis excluding patients with survival data not available. So further numerical OS improvement favoring palbociclib combination therapy indicated the impact of the missing data. Next slide. Paloma 1 and Paloma 2 combined OS analysis. You can see uh, that the in patients uh, with all patients, I had discussed it earlier. It was hazard ratio 0.9, not significant. And basically, in patients with DFI of greater than 12 months, it's hazard ratio of 0.736, and the curves have separated actually. Next slide. Post-study systemic therapies which were used in these any post-study systemic therapy, endocrine therapy, chemotherapy, or CDK4/6 inhibitor. Next slide. Next slide. Time to chemotherapy. In this, palbociclib and letrozole had more time to chemotherapy rather than the letrozole. So hazard ratio was 0.73 median. Next slide. So CDK4/6 inhibitor first time times in post-menopausal women with hormonal receptor positive to uh, uh, negative advanced breast cancer. You can see the Paloma 2 trial, the Monarch 3 trial, and the Monarch Mona Lisa 2 trial. And you can see in the less disease-free interval, in the less than 12 months, the endocrine resistant setting, Monarch 3 did not excluded that patients. And also, Mona Lisa 2 was only one patient. So basically, the Paloma 2 was the only trial having the endocrine resistant uh, setting subgroup. And next slide. So this I have again discussed that in Paloma 2 it was 22% in the disease-free interval of less than 12 months. Mona Lisa was only 1%, Mona Lisa 7%. Monarch 3 excluded these patients. And so more endocrine sensitive populations were included basically in the Mona Lisa trials. So endocrine sensitive subgroup is driving the survival benefit in Paloma 2, Mona Lisa 2, Mona Lisa 7, and Monarch Mona Lisa 3. Next slide. So effect of palbociclib in endocrine resistant patients. PFS benefit between DFI less than 12 versus greater than 12 months is similar and is significant. Hazard ratio is 0.5. And OS difference is affected by disproportionate missing survival data. So next slide. So what is an acceptable loss to follow-up missing survival data in clinical trials? In RCTs, typically investigating drugs or other therapies, it has been suggested as a loss to follow-up of greater than 20% pose serious threats to the validity of the data, and even greater than 10% may pose bias in the statistical analysis. Paloma 2 had a disproportionate loss to follow-up missing survival data between the against treatment arm and the control arm, 13% uh, versus 21%. Next slide. So clinical trial endpoint for tumor with patients with post-progression survival of greater than 12 months, and which is the best, basically, which is the best endpoint we should consider. And this was a meta-analysis report, and this showed that in patients with basically in patients with triple negative metastatic breast cancer, expected PFS is less than 12 months. Overall survival is the preferred primary endpoint. But in patients with hormone receptor negative, HER2 positive uh, metastatic breast cancer, where uh, expected progression survival is greater than 12 months in both the first and later line setting, PFS is the endpoint of choice, and OS could be considered as a primary endpoint in settings such as hormone receptor positive, HER2 negative metastatic breast cancer, given the expected long uh, post-progression survival. Uh, PFS is the appropriate endpoint. When such point patients have disease that is refractory to endocrine therapy and have been exposed to several lines of chemotherapy. And so you can see in this triple negative subgroup, the only 7 months in the hormone receptor negative HER2 positive or the hormone receptor positive HER2 positive, that's 15 months and the 27 months uh, survival. And next slide, please. Most common all-cause related adverse events, as expected, was neutropenia was more in valvocyclib and letrozole arm, and the infections was also more, and rest leukopenia was more, and anemia was also more, and rest all I will say uh, was almost similar. Next slide. Conclusions. Palomar 2 met its primary endpoint of improving PFS and other secondary endpoints. Overall response rate of 55.3% of palbociclib and letrozole versus 44% of letrozole of placebo, odds rate of 1.55, p-value 0.03 in patients with measurable disease. The safety profile of palbociclib plus letrozole remains consistent with long-term use without evidence of cumulative toxicity. Quality of life was maintained. OS was numerically longer in the palbociclib letrozole arm versus the placebo and letrozole arm, but the results were not statistically significant. Median survival of over 50 months in this population represents a significant improvement in the natural history of hormone receptor positive breast cancer. This is highlighted in the subgroup of patients with disease-free interval of greater than 12 months. 10% of patients continued on palbo plus letrozole in the study after 7.5 years of follow-up. Next slide. Interpretation of OS in Palomar 2 is limited by the large and disproportionate percentage of patients with missing survival data between the treatment arms. Next slide. Now coming to the ESMO breast cancer 2022 P-Reality X, a retrospective observational analysis of the health record using the Platron Health Analytic Database and to examine the safety and efficacy of the new drug regimens in clinical practice, the real-world effectiveness of hormonal receptor positive, HER2 negative metastatic breast cancer, initiating pelvis with letrozole versus AI alone in the first line endocrine therapy in routine clinical practice. So coming to the size of the database, and this reflects the experience across clinical centers and 8 major academic centers to 80 community cancer centers. And so single common data sets with a systemic approach to data extraction. Next slide. Palbociclib real-world first-line comparative effectiveness study extended. Objective was to evaluate the effectiveness of first-line palbociclib with letrozole compared with AA alone in patients with the hormone receptor positive HER2 negative metastatic breast cancer treated in real-world clinical practice in the United States. Method was a retrospective cohort analysis of electronic health records with the US Veteran Health Analytic Database. So the inclusion criteria was the median patients with postmenopausal of hormone receptor positive HER2 negative metastatic breast cancer, age greater than 18 years, and index date starting date of the first line of the metastatic breast cancer treatment, follow up and study, and so endpoints for the primary or the secondary OS or uh, PFS. Uh, RWF PFS was defined as the number of months from index date to the date of first documentation of the real world progressive disease or death. And statistical analysis was next slide. So bias can occur in real world data studies. Lack of parameterization in real world studies increase the risk of bias. Treatment selection is on influenced by subject characteristics. Systemic disturbances exist in baseline characteristic of subjects who administer different intervention. Systemic difference in baseline characteristics between study groups must be accounted for when estimating the effect on outcomes. RWD studies can be subject to different types of bias like the confounding bias, misclassification, reporting, selection, missing data. These are all the bias which can hamper the study results. Next slide. So statistical techniques to address inherent bias in non-randomized studies. The propensity score is the probability of a subject being assigned to a particular treatment given a subject of observed key covariates. PS-based example patient age or performance data that may impact on this treatment decision. PS-based statistical approaches can be used to create balance between treatment groups in the absence of randomization. Inverse probability treatment weighting aim to adjust for differences in the characteristics of study subjects by adjusting weights assigned to variables. Goal to create a pseudo population where all patients resemble a reference population. Advantages: keep all eligible subjects can include more than 2 comparisons. Propensity score matching to match patients across treatment groups according to demographic and clinical characteristics. To compare patients with the same propensity score but who receive different treatments. Next slide. Propensity score matching is a statistical matching technique that attempts to eliminate or reduce any bias in the real world studies that are caused by the lack of randomization. The propensity score is the probability of a subject being assigned to a particular treatment given a set of observed key subvariates. Next slide. Inverse probability of treatment weighting. This is a method that can be used to help minimize bias by real world studies by creating a pseudo population where all patients resemble a reference population. Compared to other methods, IPTW enables all eligible subjects to be included, and it is also possible to have more than 2 comparisons. Next slide. These are the baseline characteristics which are generally similar between the 2 treatment groups after including these 2 criteria and removing the bias. So, next slide. Next slide. Overall survival before and after use of this removal of bias. Unadjusted analysis, hazard ratio of 0.67 when the palbociclib and AI arm p-value was significant, and stabilized inverse probability of treatment weighing analysis, hazard ratio of 0.76 p-value is significant, and after propensity score matching analysis, hazard ratio 0.72. So median OS was significantly lower among the patients who received palbociclib and AI versus AI alone before and after the adjustment of these bias studies. The median OS was high. Next slide. So you can see in this forest plot, the OS is basically shifted to the left in all the subgroups, and overall survival, whether we see the age or the disease, visceral disease, and it favors the palbociclib and AI arm. Next slide. So coming to the P-reality X real world PFS before and after this IPTW and PSM, unadjusted analysis showed a hazard ratio of 0.68 and after this uses hazard ratio of 0.7 with the median PFS of 19.3 versus 13.9, and the using this PSM 19.8 versus 14.9, hazard ratio of 0.7, and the median PFS was significantly lower on patients who received palbociclib and AI versus AI alone before and after uses of these bias techniques. And you can see the median follow-up was 25 months versus the AI of 23.3. And next slide. So time to chemotherapy, palbociclib plus AI was associated with a delay in time to treatment versus AI alone. And median time to treatment for chemotherapy in palbociclib and at AI was 37.4 months versus 29.2 months. And median time to treatment was delayed by 8.2 months with palbociclib and AI versus AI alone in patients with hormonal receptor HER2 negative metastatic breast cancer. Next slide. Palbociclib plus AI was considered a significantly extended PFS2 versus AI alone, and PFS2 for patients receiving palbociclib and AI was 32.6 months compared to 20.7 months in those with receiving AI alone. Hazard ratio was 0.62 and p-value was significant. And next slide. Strength of P-reality X, the large sample size drawn from an extensive database comprised greater than 3 million patient records from over 280 community cancer centers and 7 major academic centers across the US. Pattern database captures and processes detailed patient-level data such as demographics, diagnostic information, and extent of disease laboratory value, and ability to comparatively control arm that allows a comparison of treatment similar to randomized control trials after adjusting for potential confounders. Follow-up sufficient time to obtain medium PFS and OS estimates. Real world PFS and OS estimate. The use of statistical techniques such as SIPTW, which and PSM to balance the balance characteristics to address the bias due to lack of randomization. Next slide. Limitations. This study is a retrospective database study of electronic health record which may have missing or anonymized data and cannot determine causal relationship. Disease progression was based on the treating physician's clinical assessment of interpretations of radio or pathological result rather than the standard criteria. Further assessment scans were not visualized with respect to timing nor requirements, while IPTW and PSM were used to balance baseline and clinical patient characteristics. Unobserved variables cannot be fully addressed through these methods. Some subgroups analyzed may not have sufficient. Younger patient age less than 50 years. Findings presented here may not be generalized to patient population not presented in the flat round database, did not collect safely. Next slide. Conclusion. In the P-reality X real-world study, palbociclib plus AI is more effective than AI alone in a heterogeneous population of patients with hormone receptor HER2 negative metastatic breast cancer, and also in patients with the various subgroups. Evidence supports the use of palbociclib in combination with aromatase inhibitor as a standard of care for first-line treatment of patients with hormone receptor HER2 negative metastatic breast cancer. Next slide. Coming to the real-world data, play an increasing role in the expanding use of already approved medications. FDA approval of palbociclib plus endocrine therapy in men with hormone receptor positive HER2 negative metastatic breast cancer. This was approval is based on data from electronic health record and post-marketing reports. Ibrance use of Ibrance in male patients from the 3 databases. Next slide. So para-cycle long study design objective to compare extended efficacy in terms of OS of palbociclib and fulvestrant versus palbociclib and letrozole. Designed extended follow-up of an international multi-center study that included patients from the prospective para-cycle study. Planned endpoints: primary was extended OS, secondary was extended PFS, extended efficacy in combined treatment arms, identification of new prognostic and predictive factors. Statistical analysis: planned recruitment of at least 388 patients with 198 deaths. The two-sided stratified long ranked had at 70% power to detect a hazard ratio of 0.7 in favor of fulvestrant plus palbociclib arm. Analysis include all patients. Next slide. So you can see the paracel long extended median PFS and median OS. Median PFS and median OS is for palbociclib and letrozole is consistent with data for our other CDK4 inhibitors. The median PFS is 34.5 months and the median OS is 61.9 months. Next slide. Indian experience with palbociclib. Next slide. So real-world experience of palbociclib used in metastatic hormone-positive, HER2-negative metastatic breast cancer in Indian population. This is the largest world data from Indian population, combining data from RGCI and BUK hospitals, Delhi, and 188 patients on palbociclib and aromatase inhibitors or palbociclib fulvestrant were included between February 2017 and May 2020. And all premenopausal women received ovarian suppression or ovarian ablation. These were the baseline characteristics of the patients taken. So the premenopausal was 108 and the postmenopausal was 80, and the brain mets presence absence, metastatic sites, and visceral metastasis, bone mets or lymph nodes. Next slide. So coming to the results, the median PFS was 20.2 months, and the median PFS in the second line was 12 months. Overall response rate in the first line was 80%, and in the second line was 47%. Toxicity 10% had grade 3 adverse, 220 patients had neutropenia grade 3-4, while no patient had febrile neutropenia. Conclusion: the present real-world data of palbociclib used in Indian population is similar effectiveness to previously published real-world data and is standard of care in first line and second line treatment of hormone receptor HER2-negative metastatic breast cancer. This you can see the subgroup analysis of the first line. It was line of hormonal therapy or second line, then the prior chemotherapy before uses of palbociclib. Yes, it was there in 87, no, and response at persist. Next slide. Palbociclib in hormonal positive metastatic breast cancer, a real world multi-center Indian experience. So this is a retrospective study from South India analyzing the real world experience of 133 patients between October 2016 to August 2019. 83 were in first line and 50 were in second line. Median age was 56 years, and median PFS was not reached in the first line. De novo metastatic versus relapsed not reached in the de novo metastatic versus in the relapsed, and bone only it was not reached versus the visceral mets. And PFS in second line median PFS was 14 months, and neutropenia was 75.2%. Conclusion: palbociclib has resulted in similar efficacy and safety in Indian patients as the Palomar trials. Neutropenia was the commonest side effect, which is uncomplicated and easily managed with dose delays, where using CDK4 inhibitors with hormone therapy has become the standard of care in hormonal receptor positive metastatic breast cancer Indian patients. Next slide. Letrozole and palbociclib in advanced breast cancer outcome from Cancer Institute, Chennai, and this was also majority had progressed while on hormonal therapy, and those who received palbociclib as second line therapy were excluded from the analysis. So you can see median follow-up 13 months, median PFS was 18 months, median OS was not reached. Next slide. Outcome of patients of hormone receptor positive HER2-negative metastatic breast cancer treated with palbociclib. This is a Jaipur-based study. 67 patients were taken. 51 were postmenopausal, 16 were premenopausal. Bone mets were 17, visceral were 30, and remaining 20 had both bony and visceral. And you can see previous adjuvant systemic therapy. Some received hormonal therapy, some had chemotherapy. Previous systemic therapy for metastatic disease, hormonal therapy, and chemotherapy. Palbociclib was commenced as first line systemic therapy in 24 cases, and second line 21, and third line beyond in 22. Next slide. Next slide. So you can see palbociclib is useful in the management of HER2 positive, HER2 negative breast cancer patient. Its benefit is confirmed in a real world setting, both in the first and subsequent lines of therapy, and the data are on similar lines as the global real world data on the palbociclib effectiveness. Now you can see the median PFS was 18.7 months in the first line and 13.8 months in the second line, and median OS was 23.2 months in the first line and 16.3 months in the second line. And later. Next slide. So efficacy and safety of palbociclib in treatment of hormonal receptor positive advanced breast cancer patient, a single center real world experience. 102 patients were treated with palbociclib plus letrozole. 100 included in efficacy analysis, and data captured from 2017 to 20, and response rate of objective response of 17%, stable disease 54%. The most reported reverse event neutropenia was reported in 13 patients, followed by chest pain and breathlessness. So, palbociclib with letrozole reported good clinical response at the end of treatment duration with a manageable, tolerable profile in the Indian population. Next slide. The practical concerns recommendation regarding the use of hormone therapy in metastatic breast cancer. The take-home messages are: in patients with metastatic breast cancer, available evidence does not support local regional treatment. The decision should be individualized based on patient and tumor characteristics, site and number of mets, and response to the systemic therapy. Endocrine therapy rather than chemotherapy uh, uh, is preferred in hormonal positive metastatic breast cancer. Chemotherapy may be offered for those who are highly symptomatic and patients with visceral crisis needing a rapid response. A combination of AI and palbociclib should be the preferred first-line hormonal therapy for hormonal receptor positive metastatic breast cancer. Premenopausal women need to undergo ovarian ablation before starting AI with palbociclib. If treatment with palbociclib is not feasible, AI should be offered in patients with bone only disease. Fulvestrant may be preferred over AI. At present, ESR testing is not recommended in routine clinical practice. Combination of fulvestrant and palbociclib should be offered to patients who progressed on AI. Exemestane plus everolimus is another option. Next slide. So summary: all of the CDK4/6 trials were designed to demonstrate a benefit in the primary endpoint of PFS. PFS is the accepted primary endpoint in metastatic breast cancer by regulatory authorities around the world. Increasing evidence is available from randomized controlled trial demonstrating longer OS with CDK4/6 inhibitors plus ET versus ET alone for hormonal receptor HER2 negative advanced breast cancer. However, the difference of OS was not statistically significant for uh, uh, palbociclib, and real-world evidence of associated OS benefit of patient treated with palbociclib combination therapy in the first line can help treatment decisions in clinical practice. According to worldwide guidelines, CDK4/6 inhibitors in combination with ET are the standard of care for patients with hormone receptor HER2 negative advanced or metastatic breast cancer. Next slide. Next slide. I think it's over.
Yes, sir.
Thank you.
Such a nice talk, sir. For the next session, I would like to invite Dr. Vineet Govinda Gupta, sir. Sir is senior medical oncologist and unit head Department of Medical Oncology, Fortis Hospital, Delhi. And the session is sponsored by Novartis. Over to you, sir.
Yeah, thank you. I hope I'm audible. Thank you, Dr. Abhishek,
Yes,
for
sir.
inviting me here. Okay. Am I visible?
Yes, sir. You are.
Okay. Okay. So yeah. So first of all, good evening to everybody. So today my topic is dilemma of choosing a CDK4/6 inhibitor in first-line MBC setting, reality or myth. So what we are really discussing is the question of the eternal question is which drug to use. So we have got 3 drugs, and the question arises again and again which drug to use. And there is a myth that all these 3 drugs are interchangeable. You can use any of them. So I'm here to discuss the differences between the 3 drugs. And for a very long time, one or the other drug has been favorite for different oncology. Different oncology like to use different drugs. And I've always been a little partial to ribociclib. So I will hope to discuss why. So fair disclosure, the slide set is from Novartis. So first question is, what are the treatment goals in metastatic breast cancer? So if you do a survey among physicians and say ki, if you are offered a particular medical therapy, what is your number one goal for your patients? The majority will put survival as the first priority. For me also, somebody asked me ki there is a new drug. What is your first priority, second priority, third priority? So personally, I will say survival is the first priority and quality of life is the second priority for me. But if you can see here, even in this survey, the first priority for most of the people is prolongation of survival. So mostly when we get a new therapy, we want to see the quality of life and the toxicity profile. But we also want to see the efficacy, and for efficacy, the most important endpoint for most doctors is overall survival. Similarly, if we have a survey of patients and ask what is their priority, most of the patients will say the life prolonging therapy is worth the side effects, and most patients want a survival benefit as their first preference. Okay, can the co-host silent? Silent? Okay, thank you. So overall survival is the most critical endpoint in any cancer drug. And most of the things like PFS, DFS, response rate, PathCR, they are meant to be surrogate for the overall survival, which is the gold standard endpoint. Now, very important, PFS benefit tracks towards improvement in survival. But it's not a gold standard, but it's not a hard and fast relationship. If you look at this scatter plot, you can see that the dots are all over the place. Drugs can be there with a very nice hazard ratio or PFS, but very dismal hazard ratio or survival. Sometimes PFS increases, survival drops. So very, very important, PFS is not a perfect surrogate. In general, increasing PFS leads to improvement in tendency to improve the survival, but improving PFS is a lot easier than improving survival. So if you look at the drugs of the trials of the CDK4/6 inhibitor, the large randomized phase 3 control trial, you can see that so far survival benefit has been realized with abemaciclib when combined with fulvestrant, that is Monarch 2, and ribociclib when combined with aromatase inhibitor in postmenopausal and pre and perimenopausal setting, and with fulvestrant in postmenopausal setting. Thus, ribociclib so far is the only drug which has shown survival benefit in all three settings. Abemaciclib has demonstrated a survival benefit in the fulvestrant-based combination, but not in the letrozole aromatase inhibitor-based combination. And unfortunately, palbociclib has failed to demonstrate a survival benefit, whether you combine it with aromatase inhibitor or with fulvestrant. So this is the main concern with palbociclib. Although I've used plenty of palbociclib, but still no survival benefit after such a long follow-up also. So it is just it cannot be dismissed as a statistical quirk. As we will discuss ahead, there are fundamental differences between the drug, and there are other trials also where ribociclib or abemaciclib have been successful, but palbociclib has not been so successful, indicating that there is a difference between these drugs, and the lack of survival benefit cannot just be attributed to a statistical quirk. There's probably is something there, although it's difficult to tease out. So on the other hand, if you look at the Monarch trials, abemaciclib, there is an OS benefit when combined with fulvestrant, but not when you combine it with a non-steroidal aromatase inhibitor. So PFS is statistically significant, but not the overall survival. So number of hypotheses can be there why there is no OS benefit, but there is a PFS benefit. Either the patient population is different, the post-progression treatment might be different, or the drug themselves might be different. So let's first look at the first hypothesis that patient population is different. So if you look at the trials, baseline characteristics, I will not go into depth into this table, but they are mostly comparable. And one way to compare the patients cross-trial, although you're not supposed to do direct cross-trial comparison, there's something called as a matched adjusted indirect comparison, or MAIC. So we know that the randomized trial of palbociclib versus ribociclib is going on, but it will be some time before we see the result. Meantime, we have to follow these kind of analytic methods where you can indirectly compare two different drug options. So if you compare Mona Lisa 2, which is riboletro versus placebo-letro, and Paloma 2, which is palbo-letro versus placebo-letro, in an MAIC, what you can do is you do pre-matching between the study populations, then you match patient by patient across the trials. You weigh the patient to match the average baseline characteristics, and then you can actually compare two trials indirectly. So it is a kind of exploratory analysis. It is a hypothesis generating exploratory analysis. So it is not a definite analysis, but it can be used to answer questions where getting the direct trial is difficult. So in the MAIC, we look at the PFS and OS. You can see actually in the MAIC, there is a PFS there is a non-significant PFS benefit towards ribolatro with a 95% CI of 0.58 to 1.1 and a hazard ratio of 0.1, but there's a significant OS benefit with a hazard ratio of 0.68 and 95 CI of 0.48 to 0.96 favoring ribociclib, indicating that even with an indirect kind of MAIC analysis, there seemed to be a tendency to OS benefit with ribociclib, but not with palbociclib. If you look at there is one more point might be the small difference in inclusion criteria between Monarch 3 and Monalisa 2, you can see here. So, but if you suppose you exclude that population, if you look at just this patient population, which is there in Monarch 3, but not in Mona Lisa, even there you can see that there is a survival benefit in Mona Lisa 2, but similar survival benefit are not realized in Monarch. So, second point is the quality of life. So very, very important whenever we want to give some kind of therapy, we want to also focus on quality of life. And just because survival is increasing, it cannot be looked at into isolation. So importantly, if you look at the studies across all the studies, majority of the studies, you can see that the quality of life is maintained or improved. And importantly, the kind of side effect you see with CDK4/6 inhibitor, most of the patient actually, they are willing to accept those kind of side effects which are commonly seen with CDK4/6 inhibitor. If you look at the MAIC based analysis comparing ribociclib with abemaciclib, the ribociclib seems to be providing a better symptom related quality of life versus abemaciclib. So one of the reasons which has been hypothesized is that drugs are different, and probably that is the main culprit, but we'll discuss it in more detail. So very important, the kind of receptors or kind of TKIs which are inhibited, they are different for different drugs. So one of these is the difference between CDK4/6 and CDK4. So in general, CDK4 dependent lines are more important for breast cancer control, and CDK6 lines are more important for hematopoietic side effects. And if you look at the CDK4 to CDK6 ratio, actually the ratio is least for palbociclib, and it is significantly better for ribociclib and abemaciclib, indicating that the tendency to selectively inhibit the breast cancer line is poorer for palbociclib compared to ribociclib and abemaciclib. One more thing is when you use these drugs, it induces distinct molecular signature in breast cancer cells, and specifically abemaciclib tends to have more of interaction with off-target kinases than palbociclib and ribociclib. You can see in this diagram. And at clinically relevant doses, generally you would expect that ribociclib will provide the better CDK4 inhibition. So there was one more interesting study. In this study, they said they looked at what is the change in the tumor gene expression profile when you treat the patient with the CDK4/6 inhibitor. So you can see that patient who got ribociclib, the patient who were basal-like, most of them continue to remain basal-like, but many of the patients who were luminal B and HER2 enriched kind of GEP, they were transformed into luminal A and luminal B respectively, and reducing the number of patients who had a HER2 enriched kind of phenotype. Therefore, it is quite likely that ribociclib induces a transformation of the cell into a less aggressive kind of gene expressing transcriptome, which might be responsible for the kind of carryover effect which has been seen in this study, that a patient who received this drug, even their PFS2 seems to be a little bit better than the control arm. Although in the second line, they are not receiving the drug. The same is not true for the other drug like palbociclib. So you can see here actually, with palbociclib, there seems to be a worsening in the GEP profile of the tumor with treatment, and tumor seem to be changing into a more aggressive transcriptome. So let's talk about the subsequent therapy in the palbociclib versus ribociclib arms. So one very interesting thing which was noted in Mona Lisa study is that patients who, after completing the first line ribociclib with letrozole, in the second line also, you can see that majority of patients, they responded, patient who had received ribociclib, they had a longer PFS2 compared to patients who were in the placebo arm. So ideally, the kind of therapy you are giving in the first line, you could assume that it should not affect the PFS in the second line. But probably because of the change in the tumor biology, as a result of the drug, the PFS2 was also improved in patient who got ribociclib compared to a patient who got placebo, which is probably partly responsible for the improvement in overall survival. While same was not noticed with palbociclib in the Paloma trial, you can see here for most of the patients who got placebo, the duration of the second line therapy is actually longer or similar to the duration of PFS2 in patient who got the first line therapy, indicating a difference between the drugs. So what about the guidelines? So guidelines, very important. When you are dealing with guidelines, the very important is the kind of endpoint which the drug has been proven successful for. So if you look at the NCCN guidelines, which are the latest ones, the category 1 recommendation are only for the drugs which have been proven to show survival benefit. So category 1 is aromatase inhibitor with ribociclib, fulvestrant ribociclib and fulvestrant abemaciclib. And if you look at the ESMO magnitude of clinical benefit scale, which is MCBS, the highest score is actually attributed to ribociclib because it has shown a survival benefit. And one more very important point, which is not there actually in these slides, there are other studies which have shown that ribociclib can achieve outcomes which are not achievable by palbociclib. Specifically, I want to talk about two studies. One is the adjuvant CDK4/6 inhibitor study. That is, if you compare the Pallas and Penelope trials to the Monarchy and the Natalie trials, the benefit of palbociclib seemed to be relatively shorter lived. So Natalie, of course, follow-up is left, but abemaciclib we now have off therapy follow-up of considerable duration, and the DFS curves are still separated and they have not rejoined. Unlike Pallas and Penelope, where the DFS benefit was short lasting and the trials rejoined themselves. Similarly, if you look at the post therapy, so if the patient has used CDK4/6 inhibitor with frontline hormone therapy, if you look at the PACE versus the maintained trial, there is still a benefit realized with the use of ribociclib, but similar benefit was not shown with palbociclib. Taken together, all this seems to point that there is some difference between the CDK4/6 inhibitor, which translate into improved clinical outcomes. And due to their pharmacokinetic profiles and pharmacodynamic profiles, probably ribociclib and probably abemaciclib are expected to be a little bit more effective than palbociclib. And same is my experience. There are number of examples, both in preclinical research and phase 3 trials, to demonstrate this. And ribociclib is the only CDK4/6 inhibitor showing OS benefit across multiple lines of therapy, endocrine partner and menopausal studies, with maintained quality of life, and also supported by guidelines as the preferred choice for patients. So if I talk about my personal preference, I am even now after generic palbociclib, for patients who are affordable, usually I would prefer ribociclib or abemaciclib compared to palbociclib. However, it is good to have a cheap option for patients, and I am a generous user of palbociclib as well. Each drug has its own pros and cons. One major advantage of palbociclib is the lower monitoring required and the lower cost. But all things taken into consideration, I do feel that ribociclib constitutes a better candidate for patients who can afford it and who can manage the monitoring. So we'll end with this, and thank you very much.
Thank you, sir. For the next talk, I would like to invite Dr. Abhishek Bansal, sir. Sir is consultant medical oncologist, SSB Hospital, Faridabad. The next session is sponsored by AstraZeneca. Over to you, sir. Abhishek, sir.
You can put on the slides, please.
Sure, sir.
So I will speak on the topic how I treat extensive stage small cell lung cancer with durvalumab real world experience. Next slide. So coming to an interesting case of 35-year-old gentleman in June 2021, complaint of change in voice which slowly progressed to aphonia or dysphonia, and comorbidities were none. Smoking history was present. A visit to ENT showed vocal cord palsy. Underwent CT brain, head and neck and chest, which was normal. No, okay. CT chest it was not normal. CT chest showed a mild enhancing soft tissue with surrounding fibrosis in left typical segment, multiple enlarged conglomerate necrotic left lymph node in left hilar, paratracheal and paraesophageal region. Hepatopulmonary window forming nodal mass compressing left pulmonary artery. Next slide, please. Based on CT scan finding, patient was started on ATP, patient condition worsened, patient had an episode of seizure and started on anti-epileptic drugs, and follow-up MRI brain was done, which showed. Next slide. 2 into 1.9 into 1.7 centimeter size, marginally enhancing intra-axial lesion, right temporal lobe with mild surrounding edema without appreciable uh, mass effect, and multiple subcentric side lesions in bilateral temporal and left frontal parietal occipital lobes. Next slide. HRCT thorax as well in upper lobe with mediastinal extension and placement of left pulmonary artery, mediastinal lymph node, and consolidation in left upper lobe. Next slide. These are the PET scan you can see on October 2021. Next slide. Next slide. So histopathology showed small cell neuroendocrine carcinoma, PDL1 score of TPS score of 3 to 4%. So final diagnosis was based of extensive stage small cell lung carcinoma with brain metastasis. Next slide. So what will be the next step according to you? Brain radiotherapy followed by systemic therapy, chemotherapy or immunotherapy. Next slide. So treating brain mets in extensive stage small cell cancer, if it's asymptomatic, then we give the chemotherapy alone. And if it's asymptomatic with limited volume of brain mets, a higher preference for chemotherapy without WBRT. Symptomatic patients will require WBRT followed by chemotherapy. Uh, and symptomatic patient with uh, limited extent of brain metastasis will require some experts choose stereotactic radiotherapy and an alternative to WBRT. Next slide. So coming to the NCCN guidelines, you can see the extensive stage with brain mets asymptomatic will mostly require chemotherapy before initiating RT. Symptomatic will require brain RT before chemotherapy. Next slide. So coming to the chemotherapy in extensive stage small cell lung cancer, you can see the various regimens which are available. So median OS is roughly around 9.9 to 10.2 to 8 to 9 months with the various regimens which are available. Next slide. So chemotherapy was started with this patient of injection etoposide and cisplatin, and radiotherapy was also given to whole brain with hippocampal sparing followed by the boost. 9 grade 3 fractures to the gross lesions. Next slide. So coming to the guidelines in the extensive stage small cell lung cancer, you can 4 cycles of therapy are recommended, but some patients may receive up to 6 cycles based on response and tolerability after 4 cycles. So carboplatin AUC 5 and etoposide 100 mg per meter square day 1, day 2, day 3 can be combined with atezolizumab 1200 mg day 1 every 21 days for 4 cycles, followed by maintenance atezolizumab 1200 mg day 1 every 21 days. Okay, this is category 1. And other can be carboplatin AUC 5, 6 and etoposide 80 to 100 mg per meter square day 1, day 2, day 3, and durvalumab 1500 mg day 1 every 21 days for 4 cycles, followed by maintenance durvalumab 1500 mg every 28 days. This is category 1. And also we can use cisplatin the dose of 75 mg per meter square day 1 and etoposide 80 to 100 mg per meter square of day 1, day 2, day 3, and durvalumab 300 mg day 1 every 21 days for 4 cycles, followed by maintenance durvalumab 1500 mg day 1 every 28 days. Next slide. So coming to the extensive stage consolidated thoracic RT is beneficial for selected patient with extensive stage small cell lung cancer with complete response or good response to systemic therapy, especially with residual thoracic disease and low bulk extrathoracic metastatic disease. So it improves the long-term survival. And the Dutch CREST trial showed the modest thoracic RT in patient with extensive stage long cell cancer responded to systemic therapy, demonstrated significantly improved 2-year overall and 6-year month PFS, although protocol The benefit of consolidated thoracic RT is limited to the majority of patients who had residual thoracic disease after systemic therapy. Next slide. So patient was given 3 cycles of chemotherapy, and along with third cycle, the durvalumab was added, in which 1500 mg every month was given as discussed earlier. Next slide. So coming to the rationale to the use of immune checkpoint inhibitors with chemotherapy in small cell lung cancer, and immunotherapy plays a role in eliciting an anti-cancer response by modulating the patient's immune response of the tumor. The high mutational burden of SCLC may allow this tumor to be susceptible to immunotherapy. The timing of immunotherapy in relation to other therapies, in particularly chemotherapy, is critical to allow disease control and development of an immune response. The Caspian, next slide. The Caspian study is the study which approved durvalumab in extensive stage small cell lung cancer. So newly diagnosed patients of extensive stage small cell lung cancer, WHO ECOG performance status 0 to 1, life expectancy greater than 12 weeks, at least one target lesion by RECIST criteria, stratification by cisplatin or carboplatin, were given induction phase of Imfinzi and etoposide and platinum every 3 weekly for 4 cycles, or followed by maintenance of durvalumab of every 4 weekly until progression, or the standard chemotherapy, which was given up to 4 to 6 cycles, maximum up to 6 cycles every 3 weekly, and also Imfinzi plus EP for 4 cycles, plus investigation agent 5 cycles followed by Imfinzi maintenance. And the primary endpoint was OS, key secondary endpoint was PFS, ORR, OS, PFS, health-related quality of life. And Caspian allowed for investigation's choice of platinum-based therapy, patient with asymptomatic or treated brain mets. And the control arm allowed for up to 6 cycles of chemotherapy and PCI per investigation discretion. Next slide. The study design differences between the Caspian versus IMP 133, and you can see the PCI in experimental arm was excluded in the Caspian, and up to 6 cycles of chemo was allowed in the Caspian study. And cisplatin was also allowed in the Caspian study. Next slide, please. So cisplatin was allowed in the Caspian study. 6 cycles of chemotherapy could be used in the Caspian study and include patients with either asymptomatic, untreated, or treated brain metastasis. Next slide. Salient aspect of Caspian trial design: durvalumab with platinum etoposide every 3 weekly for 4 cycles as the initial treatment, followed by durvalumab 1500 mg 4 weekly until progression. Choice of platinum was allowed, cisplatin and carboplatin. OS was the primary endpoint. Control arm could receive up to 6 cycles of platinum etoposide. Optional PSPI was offered in the control arm in maintenance phase and not during durvalumab maintenance. Asymptomatic as well as treated and stable brain mets were included. Next slide. So PFS was not tested for statistical significance, but median PFS in durvalumab with chemotherapy was 5.1 versus 5.4 in the chemotherapy arm, and the hazard ratio was 0.8. And you can see the curves have separated. And next slide. Majority of patients who are progression free at 1 year remain progression free even after 2 years. Like 11% are progression free in the durvalumab arm versus 3.3% in the chemotherapy arm. And also at 1 year also it is 17 to 18% versus 5.3%. Next slide. So durvalumab plus EP is the first and only approved immunotherapy to demonstrate a statistically significant and sustained improvement in OS versus EP at 12, 34, and 36 months. 3-year overall analysis in the Caspian trial. You can see 3 patients were more alive in durvalumab with etoposide and cisplatin, like 17.6% versus 5.8%. And median OS was 12.9 months versus 10.5 months. Hazard ratio was 0.71 and p-value was significant. Durvalumab with chemotherapy improved the estimated percentage of patients alive, and clear separation of the curve is sustained with a notable flattening of the curve observed from 27 months onwards, which improved sustained a long-term OS benefit. Next slide. At 3 years, OS benefit consistently favored durvalumab with chemotherapy across pre-specified subgroups that are reflective of clinical practice in extensive stage small cell lung cancer. 3-year overall survival analysis by pre-specific subgroups in the Caspian trial showed that all the subgroups in the first plot is shifted towards the left, favoring a durvalumab arm, whether it is the age, according to the sex or performance rate or the smoking criteria, or the brain or the CNS metastasis, and race, and basically, next slide. So confirmed overall objective response rate in the durvalumab arm, 24 months was 68 months versus 58 months, and you can see the median long-term durable response was also maintained with the durvalumab arm. So three times more patients in response at 24 months with durvalumab and chemotherapy versus chemotherapy alone. Next slide. So Caspian study OS based on baseline brain mets, and in patients with brain mets, hazard ratio was 0.79, improved OS versus chemotherapy regardless of presence or absence of brain mets, and hazard ratio was 0.76. And OS and PFS benefit with first-line durvalumab and chemotherapy are maintained irrespective of the presence of brain mets, further supporting its standard of care. Next slide, please. Follow-up PET scan. The treatment received the radiotherapy 18 cycles and the chemotherapy 3 cycles and immunotherapy of 3 cycles. Next slide. You can see that the PET scan, there is clearing of the previous disease which was present. Next slide. Now, finally, on 8th of April 2022, patient received the radiotherapy as earlier and chemotherapy total 6 cycles and the immunotherapy of 10 cycles. Next slide. There is follow-up PET scan. There is decrease in the size of the area in the brain, right parieto-occipital region of the brain, with decrease in metabolically inactive minimal soft tissue thickening and AP window seen, encasing mainly in the left main pulmonary artery. No metabolically active disease elsewhere. Next slide. Imfinzi is the only immunotherapy with clinical trial data demonstrating a maintenance dose administration for extensive stage small cell carcinoma in patients with as 4-weekly protocol. So you can see the Imfinzi is given along with chemotherapy with 4 cycles, followed by maintenance of 1500 mg till disease progression every 4 weekly. Next slide. So Imfinzi with chemotherapy is more cost effective versus chemotherapy alone, as well as atezolizumab with chemotherapy for the treatment of excessive swelling long cell carcinoma. Despite long-term uncertainty over OS data, provided additional confidence in the estimated incremental benefit of Imfinzi and EP alone demonstrates the additional benefit versus atezolizumab treated. Next slide. So conclusion, durvalumab plus EPs is the new standard of care in the first-line treatment of extensive stage small cell lung cancer. First-line durvalumab plus EP has shown sustained improvement in OS compared with a robust control arm that is reflected of a real-world scenario by allowing up to 6 cycles of EP and the use of PCI as compared to the results from the IM Power 133 study. Durvalumab is the only immunotherapy that provides flexibility of choosing cisplatin, carboplatin along with etoposide. Benefit with durvalumab plus EP was observed across all subgroups, including the brain metastasis subgroups. More than 17% on durvalumab plus EP are surviving even after 3 years, showing prolonged survival benefit. Imfinzi plus EP provide a high response rate, demonstrating ongoing responses at 2 years in 3 times more patients With EPR, durvalumab offers conversely once monthly dosing in the maintenance phase. Safety findings remain consistent with the known safety profile of durvalumab and EP. Next slide. Thank you.
Sir, Rahul sir is joining in 1 minute. Hello. For the
Hi.
next session, I would like to invite Dr. Rahul sir. Sir is Director Department of Hematology and Oncology, Bone Marrow Transplant, Fortis Hospital, Gurgaon. Over to you, sir.
Thank you, Abhishek, for providing me this opportunity. I
Thank you,
think it's
sir.
a great day. So the way we have moved on to doing a bone marrow transplant with the help of Abhishek and the rest, Dr. Sanjay Rai and all, it's a commendable. It's a model to be replicated in the country. 45 bone marrow transplants, 3 mortalities, and rest of the people doing well. We had the opportunity to see people after 2 years of aplastic anemia. It's fantastic. Now moving on, making this ESI Faridabad where Abhishek functions as the center of excellence for hematology. That's a quest, and we are going to discuss that. But I would request the organizers to please display my slides.
Rishabh, kindly share the slides.
Perfect. So the whole idea of today is that first is how to diagnose myelofibrosis, because still it is a diagnosis of unknown, and I would say it is in search of a doctor, right doctor. The diagnosis in search of a doctor. So I think it's very, very imperative for all of us, if the patient presents to you with high WBC count and splenomegaly where there is no BCR ABL, think myelofibrosis. If you have got high WBC count not responding to your antibiotics, think myelofibrosis. If you have got high platelet count and left shift, think about myelofibrosis. If you have got pancytopenia with splenomegaly, think myelofibrosis. It's what the common theme is. Next slide, please. So we are going to discuss, because this is an untreatable disorder and there is not, next slide, and there is no much treatment for this. I think ruxolitinib still holds its value in today's world. Okay. Why? Because the only thing which responds, oh, you have hydroxyurea, which can artificially lower down your count. You have got thalidomide prednisolone, can help you with some constitutional symptoms. And the biggest worry with myelofibrosis, dear all, when we are all listening, is diagnosis followed by the right treatment, and people are not living longer. So if you have myelofibrosis, the age-adjusted survival will be less in myelofibrosis. So we need to take these people up to 75 years of age is very, very. So it's a well-established drug which has been in their market for 10 years. We need not talk about now. Of course, in a DIPSS score where there's low risk, you can still use hydroxyurea and live longer for many years to come by. Thalidomide, prednisolone, interferon, they're all gone out of place now. And if you have a splenomegaly, yes, sometimes splenectomy does help, but not in majority of people. But what is more important is DIPSS, except the cytogenetic risk markers, the rest is all doable in myelofibrosis at this present moment of time. So I would encourage everybody to use DIPSS to better delineate which patient can undergo a bone marrow transplant. Of course, drug is one of those things, but the ultimate cure remains bone marrow transplant. Dear all, that is what is the common theme. And now with at Fortis FMRI and at ESI, we are doing transplants left, right, and center. The cost of transplants has also plummeted down. And I've got a fair large amount of experience of 15, 20 patients on myelofibrosis with almost one or two mortalities, but rest not, how the graft functions in myelofibrosis. So it is very imperative to understand that the center which does myelofibrosis routinely needs to get referral for myelofibrosis. So approximately one-third patient have intermediate risk. Symptoms and splenomegaly have prognostic impact, is a progressive disease. Treating patients with less severe early in disease course may improve outcomes. Growing evidence of ruxolitinib, including real-world studies, improves involving 100 of patients, has shown that 25 to 30% people do have an OS benefit. And major guidelines include ruxolitinib in today's movement. And so are we have to start utilizing this drug, which is not so dangerous as we think about, except the thrombocytopenia and anemia for 8 to 12 weeks. Next slide. So it is well-established risk marker. I mean, it's a well-established drug for intermediate to and high-risk people, both as a bridge to transplant and after transplant as well. So we have used both in during the transplants and taken patient on ruxolitinib. And please remember, while referring the patients for BMT, do not stop ruxolitinib. You can actually continue ruxolitinib in peri-transplant period as well. Next slide, please. So this is a phase 3 trial clinic response in Comfort 1 and 2. You can see there's a 50% reduction by 24 weeks to 48 weeks, and it continues to persist in these forest plots and these waterfall diagrams. Next. Phase 3 symptoms, responses in Comfort 1, as we can just enlarge it and can see abdominal discomfort, pain, early satiety, night sweats, itching, all has shown a decreasing trend in the tunes of anywhere between 20 to 30%, 40% people do respond self-assessment questions in terms of getting the ruxolitinib benefit. Next slide, please. Again, if we say prolonged overall survivals, you can see your Kaplan-Meier curve. The green color denotes the ruxolitinib arm, and you can yourself see that there is always a 10% point difference between both the curves when we have to see between the control arm and ruxolitinib. It's like a meat fight where there's no other better alternative than ruxolitinib. Till the time the picatinib or momelotinib comes into the play, I think the still holds is ruxolitinib. So if you have to see myelofibrosis, it has to be seen as a proliferative variant or a spent-out variant. The proliferative variant, it is easy to give, but in a spent-out variant, you have to reduce the dose, and thus the efficacy also starts coming down. Next slide, please. So the important question, 5-year data in Comfort 1 and 2 was there's a 50% patient achieved a splenic response at that time, which was a reduction by 50%. Probability of maintaining a splenic response was 0.51 at 3 years and 0.48 in 5 years. One-third patients had 20% reduction in allele burden, which is now very common. That's why, because you have started doing more of NGS at this present moment of time. And 16% improved fibrosis, 32% had stable fibrosis, and adverse event, as we have already talked about, anemia and thrombocytopenia are the only side effects. So a fairly innocuous drug which can be used except the financial toxicity. People needs to be put on these drugs early after doing a myelofibrosis. And just a small reminder that we always have to do a biopsy to prove to prove a diagnosis of myelofibrosis. And instead of MP and reflexes, now we can start sending the NGS so as to have a better variant VAF for various mutations, because JAK2 can co-opt with ASXL1, and then it's one of the reasons where you should use Jakavi followed by transplant. So ultimately, those fit patients up to 65 years of age, transplant should be the frontline therapy after giving Jakavi. Next slide. Tolerability has never been an issue in ruxolitinib. Next slide. Does it disease modifying effect? The answer to that is yes. It does reduces the severity as well as the as well as the fibrosis in 32% people, as well as the allelic burden, thus increasing the overall survival in these. Next slide, please. So approximately one had intermediate one risk disease at diagnosis who have high symptoms burden, and majority presents with splenomegaly at the time of diagnosis with the quality of life being affected. Next slide. MF clinical risk stratification, we have already spoken about the age, the constitutional symptoms, HB, leukocyte count, circulating class, platelet. So you need to have a good hematopathologist who can look at the peripheral smear and give the circulating class, because it makes the difference in DIPSS. And the whole idea of a DIPSS is that it's a dynamic international prognostic score. It can be utilized at any disease point rather than only at the starting point of the disease. Next slide, please. MF has decreased survival risk in all the categories, regardless of the severe category. So age-adjusted needs to be done. Something needs to be done, and that's where the Jakavi in 32% people, and in rest, bone marrow transplant will help them to achieve that age which we want a normal population to live, which is like up to 75 to 80 years of age. Next slide. Symptoms affect patients in both high-risk categories, and that's one of the reasons for a quality of life being deteriorated. So it is not important how long you live. It is more important also to live a quality of life. And that's what the symptom burden actually reduces your quality of life, just not decreasing your survival at the present moment of time. Next slide. Next slide, please. Splenomegaly is a quality of life impact. Oh, of course. Decreased appetite, bony pains, joint pains, early satiety. This leads to a huge impact on the patient quality. And that's why Jakavi is one of the preferred agent to reduce splenomegaly along with hydroxyurea. Next slide. Two major challenges has been of myelofibrosis symptoms and splenomegaly. And of course, I would have to add something to that is the cytopenia in a burnout disease, because the cytopenia becomes a major challenging point because we don't have a drug right now which can be utilized except the bone marrow transplant. And by the time patient becomes cytopenic, even the transplant becomes impossible. And that's why the more experienced transplant centers like us needs to get early reference. Next. Importance of symptoms in MF, as we can talk about, the quality of life decreases. In AML and myelofibrosis is almost the same. Next. And splenomegaly and myelofibrosis, MF prognosis, as the Kaplan-Meier can show that greater than 5 centimeter, there's a poor outcomes in these subset of patients. So we need to add. So this is like a building up that splenomegaly, quality of life symptoms, or quality of life symptoms, even that B symptoms, which when they're there, does signifies the disease severity and disease advanced stage nature of the disease, which will lead to overall prognosis being poor. Next slide. So next is spleen response influences outcome. Yes, if the splenomegaly goes down, the overall quality of life becomes better. And of course, the OS also becomes better at 6 months, which is like significant at 0.04. Next. MF is a progressive disease, relentless, it just continues to grow. Even after 10 years, people do not survive. Next. And we have seen this. This is how patients seen at diagnosis and patients seen at greater than 1 year. If you can see, all the parameters have almost become double in the table itself. Next slide. Changes in spleen volume continues to increase if there is no proper treatment given to these people. Next. So treating patients with less severe early in the course disease when splenomegaly symptoms are relatively milder and likely to more responsive may lead to overall improved outcomes because you can control the disease early. And let's not save the thing for the heydays. Next slide. And this is what the curve forest plot shows, the severity index in terms of low hemoglobin and other constitutional symptoms, as we all know. And the multivariate analysis do show intermediate risk, spleen, transfusion dependency, platelet, and time to treatment for ruxolitinib are or poor markers for the outcomes in the near future. Next slide. And this is what the palpable splenomegaly better clinical outcomes with ruxolitinib initiation in less advanced disease, as you can be seen by the blue curve, that you start early and you reap the benefit early in the disease course, leading to better outcomes in the quality of life. Next. So growing published evidence, use of ruxolitinib intermediate from retrospective, including several publications involving hundreds of patients, shows widely used intermediate, one, because you don't have another choices. Response seen is as early as 4 weeks, 4 to 8 weeks is what the time remains. If you don't respond by 12 to 16 weeks, then you are not going to respond to it. Spleen and symptoms response are similar or higher among IPSS intermediate when than in overall higher risk MF population. Generally well tolerated by patient in all risk groups with similar adverse effect profile, which is anemia and thrombocytopenia. So again, I would say let's not save the things for the heydays. Next slide. Jump efficacy in low risk, intermediate, high risk shows all across the groups in jump studies. There has been a palpable benefit in terms of using ruxolitinib. Next. And this overall by survival by DIPSS scoring system, if you can see, there's a huge survival benefit in these patient subsets where the curve is almost flat, if you have to see to that. Next slide. And robust trials also shows that consistent with findings from the comfort studies that most common but their reduction in the symptoms all across risk groups were found, and spleen response was 39.6 overall intermediate 1 and 50% intermediate 2, 15.4 in high risk patients. So starting early does lead to better outcomes in splenomegaly assessment because the mutation and the burden of disease is so much in later down the line, then the drug might not function. It's just because we have missed the right opportunity to treat these patients. Next. It's a similar thing. There's no major side effects in across the groups which has been utilized. Next. Single center experience of ruxolitinib in low risk and high risk, and US and Italy that usage in all subgroups is likely to be benefited. Next. Next. All international guidelines include ruxolitinib as a treatment option for patient intermediate risk and beyond. Still in low risk disease, no, it has not been utilized, but yes, intermediate 1, 2, and high risk, it's the standard of treatment. Next. These are the major guidelines which talks about ruxolitinib. The dose is 20 milligram, which has to be adjusted according to the platelets and not because of the hemoglobin itself. Next. And these are the treatment options for ELN 2018 about splenomegaly and low risk, and we have already spoken about. To make it very simplified, the reason is that if you have an intermediate 1, intermediate 2, or high risk, start with ruxolitinib in a proliferative stage. If you have a burnt out disease, then try to use bone marrow transplant at the earliest, then not later. Next. So story is being effective in intermediate 1 and 2. 1/3 patients have intermediate disease, is a progressive disease. Less severe MF early in the disease course can improve outcomes as shown by the JUMP, ROBUST, and various US and Italian data. All major international guidelines use ruxolitinib in the guidelines. It's just that we Indians don't have a guidelines, but we need to adopt ruxolitinib early. It has been in the market for 10 years. Still, the usage is very minimal because of the fear and because of the disease being unknown to many physicians. Next slide. So I think it's a very important scene today. Next. It's very important to understand that it's a disease which is still trying to gain its foothold into the minds of the physicians by early diagnosis. And once diagnosed, then you can proceed ahead and get a ruxolitinib at the earliest, and then followed by bone marrow transplant. So I think it's very, very important that Abhishek has touched the important point on myelofibrosis, which is very dear to our heart. We often see in ESI, and you have got ESI patients, please refer it to them, to Abhishek or to us in ESI, and transplants can be done for these patients. So I think, or if they're private patients, they can always come to Fortis to get a bone marrow transplant. With this, thank you audiences for listening to me for past 15-20 minutes. And what this is the area which we have been working on. And I hope that future will be brighter for these people who are suffering from an relatively unknown disease. Thank you. Thank you to the organizers. I'm back to organizers.
Thank you, sir. Such a nice talk.
Thank you, Abhishek.
Thank you, sir. Thank you.
The next session will be by DRL. So Meet Kumar just joined by in 10 minutes. So we are decided to do the session of Suresh Patel, sir. Sir, Suresh is joining in 1 minute. Sorry for the delay, everyone. So for the next talk, I would like to invite Dr. Suresh Patel, sir. Sir is consultant medical oncology, Capitolo Hospital, Jalandhar. Over to you, Suresh, sir. Sir, you are not audible, sir. Sir, your voice is not audible.
हेलो।
ये सब
क्या हो रहा है?
सर का वो ऑडियो कनेक्ट नहीं हो पा रहा था सर, वो रिजॉइन कर रहे हैं। So your voice is not audible. Suresh sir, can you hear us? Hello.
Hello, hello.
Yes, sir. You audible.
Okay, am I audible? Okay.
Yes, sir. Rishabh, kindly present the slides, please.
So, technical issues. So, a warm good evening to everyone. Uh, I would like to thank Dr. Abhishek Bansal and all the organizers for giving me the opportunity to speak on the topic of panitumumab and RAS mutation, which is whether it is diagnostically useful gene mutation for metastatic colorectal cancer. We are going to discuss in detail regarding the paradigm study. Next slide, please. So we are going to discuss whether RAS wild type tumors, which are microsatellite stable metastatic CRC, does anatomical site matters in such cases? Next slide, please. So as we know that we have a molecular classification for metastatic colorectal cancer, which is classified as per CMS 1, 2, 3, and 4 subtypes. So CMS 1 subtype is immune stable subtype, in which is predominantly seen in the proximal colon, and the main hallmarks are mostly MSI high tumors with high CIMP mutations, BRAF, and low prevalence of SCNA. Then we have the CMS2, which is canonical type tumors, which is the most common subtype, and it is predominantly seen in the distal colon and rectum site. And the main hallmarks regarding it is a high CIM and CIMP tumor with WNT and MYC mutations. Then we have the CMS3 subtype, which is the metabolic subtype, which does not have a site predominance, and the main hallmarks are it is associated with enrichment in KRAS mutations with moderate and low MSI status, intermediate CIMP with PIK3CA mutation, and overexpression and without BRAF mutations. Then we have the fourth subtype, which is the mesenchymal subtype. It is predominantly seen in the distal colon and rectum sites, and the main hallmark is TGF beta activation, mesenchymal epithelial transition, and it is associated with high number of fibroblasts in the tumor. Next slide, please. So what is the analysis of this tumor sidedness? So when we look for the comparison between right-sided CRC and left-sided colon cancer, you can see we know that right side is derived from the midgut, whereas the left side is derived from the hindgut. Also, when we look at the right-sided tumors, it is more likely MSI high, CIMP high, BRAF mutated, KRAS mutated tumors. Then on the left side, if we look at the type of mutations, it is mostly aneuploidy, T53 mutated, APC and KRAS, and SMAD4 mutation type tumors. Right-sided colon cancer most commonly are of CMS1 molecular subtype, whereas on the left-sided we have the CMS2 subtype more common. Right-sided tumors have a worse prognosis, and also they also lack benefit from anti-EGFR therapy, which we are going to discuss further. Next slide, please. So this is the FIRE-3 trial, which was FOLFIRI plus bevacizumab versus cetuximab comparison for PFS and overall survival data by tumor location. So when we look at the PFS curve, which are the above two graph, you can clearly see that there is not much wider separation of the curves in the left-sided tumors and even the right-sided tumors. But when we come to the overall survival data, definitely there is a wider separation of the curve with improvement in cetuximab plus FOLFIRI based therapy as compared to the bevacizumab plus FOLFIRI based therapy. Whereas in right sided there is not a separation, and also there is no much overall survival benefit. Next slide, please. So when we look at the CLGB SWOG 80405 study, which was FOLFIRI or FOLFOX with bevacizumab or cetuximab based therapy and overall survival by tumor location. When we look at the overall survival data in the cetuximab arm, or left-sided tumor did better with the median overall survival being around 40 months in the 39 months in the patients who received cetuximab as compared to only 14 months in the patient who in the right-sided tumors. When we come to the bevacizumab based therapy, the overall survival was almost similar, which was around 30 to 32 months. Next slide, please. So these are the trials which shows that panitumumab provided better outcomes than the comparator in the left-sided tumors. So first we have the PRIME study, which was used for first line treatment for panitumumab plus FOLFOX based therapy, in which the overall survival was 32.5 months as compared to only 23 months in the patients who received only chemotherapy, with a hazard ratio of 0.67. When we come to the PEAK study, which was first line treatment with panitumumab plus FOLFOX versus bevacizumab plus FOLFOX, it showed that the median overall survival was 43 months in the patient who received anti-EGFR therapy, whereas it was only 32 months in the patient who received anti-angiogenic therapy. When we come to the study 181 study, which was second line treatment for panitumumab plus FOLFIRI versus FOLFIRI based therapy, the median overall survival was 20.1 months in the patient who received panitumumab, whereas it was only 16.9 months in the patient who received alone FOLFIRI based chemotherapy. Thus, panitumumab plus chemotherapy provided benefit over chemotherapy with or without bevacizumab in the left-sided tumors. Next slide, please. So we are going to discuss regarding the paradigm trial, which was the first line panitumumab versus bevacizumab in combination with FOLFOX for RAS wild type metastatic CRC tumors. Next slide, please. So what was the background of the trial? In this trial, adding an anti-EGFR agent or anti-VEGF antibody to chemotherapy improved the overall survival of patients with unresectable metastatic CRC up to 30 months. In comparative trials of post-hoc analysis of the RAS wild type tumors, patients show inconclusive results, as we have discussed in the US CLGB SWOG study, in which the overall survival was similar for cetuximab and bevacizumab. In the FIRE-3 study, cetuximab improved overall survival versus bevacizumab with a hazard ratio of 0.7. So the benefit of an anti-EGFR antibody may be enriched in RAS wild-type tumors with primary tumor originating in the left side of the colon and the rectum. So Paradigm is the first prospective trial to test the superiority of panitumumab versus bevacizumab plus standard chemotherapy for patients with RAS wild-type and left-sided metastatic CRC patients. Next slide, please. So in the Paradigm trial, the design was that the patients with unresectable disease with no previous chemotherapy, with age subgroup was 20 to 79 years with a good performance status of ECOG PS 0 to 1 and with at least one evaluable lesions and most of all the patients were RAS wild type metastatic CRC patients. They were randomized 1:1. In one arm, it was panitumumab plus FOLFOX6, and the other arm received bevacizumab plus chemotherapy. The primary endpoint of the study was overall survival. Left-sided population, if significant, analyzed in the overall population. Secondary endpoints were PFS, response rate, duration of response, R0 resection rate, left-sided and overall population safety, and all treated patients. Next slide, please. So, what was the statistical consideration? On final analysis, overall survival was the primary endpoint, and this was hierarchically tested in the following order. All data reported or based on the database block of the February 10, 2022 data. In the primary endpoint 1, overall survival in the left-sided population was assessed, and in the primary endpoint 2, overall survival in the overall population was assessed. Next slide, please. So these were the baseline patient characteristics in the left-sided and right-sided population patient and the overall population, which was as per the age subgroup, sex, performance status, tumor location, whether it was left-sided tumor or right-sided tumor. Also subgroup was done as per the number of metastatic organs with site of metastasis being liver or as liver as only the site of metastasis. As we know, only liver site of metastatic patients can go for further resection if it is oligometastatic disease. Also, prior treatment history was taken, whether there was primary tumor resection, whether radiation or adjuvant chemotherapy was received or not. Next slide, please. So what was the primary endpoint? The primary endpoint of the study was overall survival. So when we look at the left-sided population subgroup graph of Kaplan-Meier survival curve, you can see that the panitumumab plus FOLFOX6 arm did better as compared to the bevacizumab plus FOLFOX chemotherapy arm, in which the median overall survival was around 38 months in the patients who received panitumumab plus chemotherapy, and it was only 34 months in the patient who received bevacizumab plus chemotherapy, with a hazard ratio of 0.82, which was statistically significant. When we come to the primary endpoint 2, which was overall survival in the overall population, also it was found that the patients who received panitumumab plus FOLFOX6 did better as compared to the patient who received only bevacizumab plus chemotherapy, with a median survival being around 36 months in the arm which received panitumumab plus chemotherapy, and it was only 31 months in the arm which received bevacizumab and chemotherapy. Next slide, please. So when we come to the progression-free survival in the left-sided population, panitumumab for FOLFOX6, when compared with bevacizumab, there was not much wider separation of curve, with the median PFS being almost similar, around 13.5 months in both the arms. When we come to the overall population, the hazard ratio was also not statistically significant, with not showing a much significant improvement in the PFS in both the arms on comparison. Next slide, please. So when we come to the overall survival as the primary endpoint, when we look at the panitumumab plus chemotherapy arm, the median overall survival was 38 months in the left-sided population, whereas it was only 34 months in the bevacizumab plus chemotherapy arm. Whereas in the overall population also, when we see panitumumab did better with a overall survival of 36 months, whereas it was only 31 months in the patients who received bevacizumab plus chemotherapy. Also, the hazard ratio p-value was hazard ratio was 0.82 in the left-sided population, and it was statistically significant. So overall survival outcomes were generally consistent across all the patient subgroups in both left-sided and overall population in the paradigm study. Next slide, please. So when we come to the PFS, when we look at the PFS in the left-sided CRC population, the median PFS was 14 months, whereas it was only 13 months in the arm which received bevacizumab plus chemotherapy. But when we come to the overall population, the PFS was around 13 months 12 to 13 months in both the arms. However, the hazard ratio was not was 1.01. Next slide, please. So when we look at the other efficacy outcomes and the secondary points, the response rate in the left-sided population was around 80%, whereas it was only 68% in the bevacizumab plus chemotherapy arm. But when we look at the overall population data, it was 75% in the panitumumab plus chemotherapy arm, and it was only 67% in the bevacizumab plus chemotherapy arm. When we look at the median duration of response, it was around 13 months in the panitumumab plus chemotherapy arm, and it was only 11 months in the other arm in the left-sided population, and it was 12 months in the overall survival population for panitumumab, and it was 10 months in the bevacizumab plus chemotherapy arm. You can clearly see that the R0 resection rate, it was around 18% in the panitumumab plus chemotherapy arm in the left-sided population, and it was only 11.6% in the bevacizumab plus chemotherapy arm. Also, when we come to the overall population, it was R0 resection rate was around 16%, whereas it was only 10.9% in the overall population which received bevacizumab plus chemotherapy. Next slide, please. So now we discuss regarding the adverse events which are reported in the panitumumab plus chemotherapy arm. The most common adverse events were in the form of skin rash, peripheral neuropathy, and other side effects like diarrhea, nausea. Whereas in the bevacizumab, the most common reported side effects were neuropathy, and some patients even reported decreased neutropenia and decreased platelet count, and was also reported in the bevacizumab and FOLFOX6 chemotherapy arm. Next slide, please. So when we come to the overall survival as per subgroup analysis in the right-sided population, so you can in the forest plot you can clearly see that on the panitumumab receiving population, some of the subgroup did better, especially on the primary tumor resection, whereas most however it was not comparable in the both other arms on subgroup analysis. Next slide, please. So when we come to the PFS and other efficacy outcomes in the right-sided population, you can see that there is not much progression-free survival in the patients in both the arms, with a response rate of around 55% in the panitumumab plus chemotherapy arm, and it was around 63% in the bevacizumab plus FOLFOX6 arm in the right-sided population. And the median, when we come to the R0 resection rate, it was almost similar, 10% in both the arms. Next slide, please. So what was the conclusion? The phase 3 paradigm trial met the primary endpoint, demonstrating the superiority of first-line panitumumab versus bevacizumab in combination with FOLFOX6 in left-sided and overall metastatic CRC population. In the left-sided population, the median overall survival was 38 months versus 34 months in the other arm, with a hazard ratio of 0.82, which was statistically significant. When we come to the median overall survival, it was 36 months in the panitumumab arm versus 31 months in the bevacizumab plus chemotherapy arm. The median overall survival exceeded 36 months in the panitumumab patients, while those in bevacizumab were consistent with previous reports. When we come to the right-sided tumors, the median overall survival was 20 months in the panitumumab arm, and it was better, around 23 months in the bevacizumab arm, with a hazard ratio of 1.09. Although PFS was comparable between two arms, the response rate and R0 resection rates were higher in the panitumumab in the left-sided and overall population as compared to bevacizumab. In the left-sided tumors, the median PFS was 14 months, whereas it was 13 months, and the response rate was 80%, whereas it was only 68% in the bevacizumab arm, and the resection R0 resection rate were 18% versus 11% in the bevacizumab arm. When we come to the overall median PFS, it was 13 months in the panitumumab arm, and it was only 12 months in the other arm with a response rate of 75% in the panitumumab arm and around 67% in the bevacizumab arm with a R0 resection rate of 16.5% versus 10.9%. These results support panitumumab plus FOLFOX6 as the first-line therapy for patients with RAS wild-type left-sided metastatic CRC. Next slide, please. So what is the key takeaway? Not only a significant interaction between the treatment effect and primary tumor location is evident in the term of overall survival and PFS, but also in terms of overall response rate. This confirms the suboptimal activity of anti-EGFR therapy in the right-sided tumors. These results clearly challenge the recommendations provided by the latest ESMO guidelines to consider the use of anti-EGFR as upfront targeted agents also in right-sided tumors when cytoreduction is the primary objective of the first-line treatment, also in the perspective of conversion to resectability. At the same time, the importance of primary tumor location, whether it is right or left-sided tumor, does change the therapeutic choice in first-line treatment of RAS wild-type metastatic CRC patients and leading to identify double anti-EGFR therapy in the future for better improvement in therapy in left-sided tumors and to consider for anti-angiogenic therapy in right-sided tumors. Next slide, please. Thank you.
Thank you, Suresh sir, for such a nice talk. For the next talk, I would like to invite Dr. Meet Kumar sir. Meet Kumar sir is Director and Head of Department in Hematology and BMT at Maringo Asia Hospital, Gurugram. And next session is sponsored by Takeda. Rishabh, kindly play the video, please.
Can I share my screen?
Just 1 minute. This video will be presented by the Takeda, no? Meet sir, kindly share your slides.
Are my slides visible?
Yes, sir.
Okay, so first of all, at the outset, I must thank and congratulate Dr. Abhishek Bansal, my dear friend from Faridabad, for having organized this wonderful meeting, an academic meeting, where I think all the sort of brains are put in place to discuss various aspects of solid and liquid oncology. Also, I would like to thank Takeda for having given me this opportunity to discuss about their new molecule of brentuximab vedotin, also branded as etc. That I think every one of us who is sitting here has heard of it for sure, and many of us or most of us have used it. So the concept is that the patients of Hodgkin's lymphoma, those patients we know as clinical oncologists and hematologists and medical oncologists, that these patients, most of the times when we see a patient of Hodgkin's lymphoma who is newly diagnosed, who walks into the OPD, we are having a smile on our face because we know that most of the times these type of patients are going to get good chances of cure, almost to the tune of 80 to 85% chances that these patients who are otherwise not so high risk will get cured for their life with the use of conventional chemotherapy. But what happens to the remaining 15 to 20% of the patients? That is what is something that has been in research for many years, because these are the 15-20% patients who ultimately do not respond to any conventional chemotherapy, and there was a much of an unmet need to address those patients. That how do we tackle these patients? Most of the time, until the availability of the immunotherapy, we had been using different regimens, chemotherapy regimens for different time points. Everyone has had its own favorite chemotherapy regimen, whether it is GDP, ICE, DAP, ESHAP, whatever. But every one of us was using some type of chemotherapy regimen whenever these patients did not fare well to the frontline chemotherapy. But definitely, most of us who have used etc., like in the current sort of era, would know that this molecule has done sort of benefit to these patients in terms of achieving responses, deeper responses in patients who are newly diagnosed, and also in patients who are otherwise difficult to treat and who has got a relapsed refractory disease. In those patients especially, this molecule has done some good responses where the patients who are otherwise unable to be taken up for an autologous transplant consolidation, those patients could ultimately proceed to autologous transplant after achieving remission with etc. This is the area which has appealed, at least me, the use of etc. the most, because those patients, without being exposed to additional chemotherapy, toxic chemotherapy, they are getting into remission. They can ultimately proceed to autologous stem cell transplant or allogeneic stem cell transplant, whatever is required clinically for them. So, like in the next maybe 10 minutes or so, what I will be doing is I'll be discussing about etc. Brentuximab vedotin in different clinical contexts in Hodgkin's lymphoma. So that's a disclaimer. So if we talk about the evolution of the treatment for Hodgkin's lymphoma, it has been in clinical practice since many years. Initially, the only chemotherapy regimens were available, and slowly and steadily the chemotherapy is improvised. But the chemotherapy regimen that has stood the test of time in upfront chemotherapy is ABVD. Slowly and steadily, questions started to be raised for the ABVD chemotherapy because of its side effects, not essentially because of its effectiveness, because it is still one of the most effective chemotherapy regimens, but mainly because of the side effects, in the sense that toxicities associated, especially the long-term toxicities associated with ABVD, are significant, be it infertility, be it pulmonary fibrosis, be it sort of other cardiac toxicities. These toxicities did sort of, or long-term side effects of secondary malignancies. These were the actual side effects that were sort of the major cause of concerns for ABVD, to the extent that in pediatric patients, ABVD has been modified and some other chemotherapy regimens instead of ABVD have come into picture. So when we talk about etc. as the molecule, these are the areas where this has been tried. The trial data I'll be discussing very briefly in the next couple of minutes. In frontline patients, the trial that proved its mettle in sort of upfront treatment of classical Hodgkin lymphoma, especially in advanced stages of this disease, was at Echelon trial. So this is the conventional therapy regimens that we have been using. bleomycin associated toxicities, be it infertility or pulmonary fibrosis, has been a cause of worry, and that was the rationale for the Rathel trial, where the bleomycin was omitted after 2 cycles, where those patients who were in complete metabolic response and they continued alone on AVD and bleomycin was omitted, that did not affect the long-term outcomes, and the toxicities could be significantly brought down. So both pneumonitis in short term and fibrosis, risk of fibrosis increased in the long term who are exposed to increased dosages of bleomycin beyond 2 cycles. This risk especially is higher in patients who are elderly, and the chances of the bleomycin-induced lung toxicity is higher in these patients. When we talk about Adcetris, in Hodgkin's lymphoma, it has been approved, as had been shown in the previous video as well. It has been used in upfront treatment setting for advanced stage classical Hodgkin's lymphoma in combination with chemotherapy, that is stage 3, stage 4 classical Hodgkin's lymphoma, in patients who are relapsing at any time point. For those patients also Adcetris or blentuximab is approved, and especially in patients who are high risk for relapse after autologous transplant. In those settings also sort of brentuximab has been approved as a consolidation, post-transplant consolidation strategy. So that's the first paper that was published of its efficacy in 2017 in NAGM for the efficacy of brentuximab in advanced stage classical Hodgkin's lymphoma. That's a study design, randomization to ABVD versus brentuximab plus AVD, a total of 6 cycles, end of treatment CT scan was done, and thereafter a follow-up PET CT scan was done every 3 months for 36 months. The primary endpoint was modified PFS, and the secondary endpoint was overall survival. That's the regimen that had been used. So this is the total sort of data. The study started recruiting in November 2012 till January 2016. The patients were recruited, and thereafter the patients have been followed up regularly. The slight difference in the modified PFS as compared to PFS that we are conventionally using for response assessment. In this case, modified PFS was used. That just means that instead of the perfect complete response, even partial response was considered as a parameter for progression-free survival. So the censorship was done at partial response as against the complete response for conventional progression-free survival. That's the baseline characteristic of the patients in the 2 cohorts. Large number of patients, 660 and 670 patients in either of the arms, with most of the baseline parameters being comparable. This is what we were talking about. The modified progression-free survival was significantly better in the Adcetris arm as compared to the ABVD arm. The 2-year modified progression-free survival was 82% versus 77%. So there was a 23% reduction in modified PFS as compared to ABVD in brentuximab ABVD arm. So there was a long-term follow-up study that has been published later on. That was a comparison of 2-year versus 6-year follow-up data. And in this data, again, the efficacy of brentuximab arm as compared to conventional ABVD arm was proven. In the progression-free survival curves, as we can see, there was 32% reduction in the risk of disease progression in the brentuximab arm as compared to ABVD arm. And interestingly and importantly, the first molecule that showed the overall survival benefit in patients with Hodgkin's lymphoma was this brentuximab molecule, with a 41% reduction in the risk of death from Hodgkin's lymphoma as compared to ABVD. When the responses were sub-analyzed according to the PET response, interim PET response after 2 cycles, that again showed that either in the patients who achieved the PET negativity or those patients who remained PET positive after 2 cycles of either of the arms, in both the arms, the responses and the outcomes as compared to progression-free survival were superior in the Adcetris arm as compared to the conventional ABVD arm. So when they compared about the time to requirement of the subsequent therapies, the number of patients who required subsequent therapies were more or higher in the conventional ABVD arm as compared to the Adcetris arm, as can be seen in both the curves at 2 years as well as 6 years. The patients who required subsequent chemotherapies were higher in the ABVD arm as compared to brentuximab arm. The chances of developing secondary malignancies again were superior in the ABVD arm. We know that secondary malignancies are a more commoner side effect associated with conventional chemotherapy as compared to immunotherapy. So secondary malignancies were higher in the ABVD arm. Also, there was no statistical difference observed between the two arms in the number of reported pregnancies in female patients. So that means brentuximab, when incorporated into the treatment regimen, it helps in preserving fertility as compared to brentuximab and vinblastine-induced infertility that we see commonly in patients who have been treated conventionally for years with the conventional EBVD arm. The only problem and the side effect associated significantly with the brentuximab is the peripheral neuropathy. And when that was compared as compared to EBVD, the incidence and the side effect profile of brentuximab was superior in terms of higher peripheral neuropathy that was seen of all grades in the brentuximab arm. However, as the time advanced, so 2 years, the incidence and prevalence of peripheral neuropathy was quite high, to the tune of 67%, all grade peripheral neuropathy as compared to 43%. But at 6 years, the peripheral neuropathy was significantly reduced from 67% to 19% in the 6-year long-term follow-up plan. The neutropenia was higher in the sort of ABVD arm, of course, as compared to brentuximab arm. However, there was an interesting finding that in patients in the etc. arm who also received prophylactic GCSF, in those patients, the survival was superior, as can be seen in this curve. The blue curve is the brentuximab AVD with GCSF, and the red one below that is the brentuximab AVD without GCSF. There was slight tendency towards improved survival or progression-free survival in the patients who received prophylactic GCSF. So that is the summary of the Echelon 1 trial. There is a OS advantage that has been demonstrated in this study. There has been attempts to reduce the toxicities that are associated with sort of the conventional ABVD arm, and the prolonged study data does show that there is a significant benefit in OS and all the secondary endpoints as far as the etc. arm is concerned. So this is how the role of brentuximab upfront has come, especially in the advanced stage patients. When we talk about relapsed refractory patients, this is the trial that compared this is single arm trial that sort of analyzed the responses of brentuximab vedotin in patients who had multiple lines relapsed refractory Hodgkin's lymphoma, including who had failed an autologous transplant. In those patients, the primary endpoint was overall response, and the secondary endpoints were duration of response, CR, PFS, OS, and safety. So when we talk about overall response, 75% patients responded in this arm who received etc. Out of those 75%, 34%, that's a significant number, in multiple line refractory Hodgkin's lymphoma, 35% patients achieved a complete response. When that was compared with the degree of response, most of the patients had a significant reduction in the SPD in the individual patient cohort. The probability of survival, of overall survival and progression-free survival at 5 years did show a benefit in terms of median OS was 40 months, and the 5-year overall survival was 41%, and the 5-year overall survival, progression-free survival was 22%. So there was significant improvement in those patients who have failed everything, including an autologous transplant. In those patients, if etc. is able to give a progression-free survival to almost 1/5 or more of patients, that is quite a significant response. Of course, the purpose of this response will ultimately be to be used as a bridge to allogenic transplant in those patients who have responded to etc. and should be taken up for an allogenic transplant. So when we talk about patients, like those patients who responded, who achieved a CR, 38% of those patients remained in remission at long-term follow-up. So 40% patients of the initial 34% patients who had achieved CR, those patients remained in remission for 5 years or beyond. So as the number of cycles advance, the chances of achieving a more and more number of responses increases. We know that, and that is the reason why the brentuximab has been now included into the as a treatment option for patients who have got a relapsed refractory Hodgkin's lymphoma, including using this as a maintenance treatment, even if they are not proceeding with an allogenic transplant. So what about the post-autologous transplant consolidation? This is another area where we have used sort of a couple of patients, phase 3 trial, wherein the patients who had a high-risk Hodgkin's lymphoma were randomized post-transplant to receive brentuximab every 3 weeks for a total of 16 cycles. A large number of patients randomized, 329 patients. The primary endpoint was progression-free survival, and the secondary endpoint was overall survival. Needless to say, the patients who received Etcetris as compared to placebo for maintenance treatment post autologous transplant, those patients who received Etcetris had a 43% reduction in the risk of relapse or progression as compared to placebo. The probability at 5 years to achieve a progression-free survival was superior in the brentuximab arm, 60% versus 40% for the placebo arm. So that is the recommended dose and frequency. For every area, it is 1.8 milligrams per kg. As we know, we have been using conventionally every 3 weeks. However, for upfront treatment, when it is combined with AVD, the dose of Etcetris is 1.2 milligram per kg. So I think with this, we can just summarize and close this. We have discussed all the data, and brentuximab in all the preclinical setting has proved its mettle, be it be upfront advanced Hodgkin's lymphoma setting, be it be relapsed refractory setting, or be it be post-transplant consolidation stroke maintenance setting. Every place sort of Etcetris has has been shown to be effective in terms of prolonging progression-free survival and at some places overall survival. So I think we can just end with this and hand back to the organizers.
Hello, sir. Thank you for the nice talk. Sir, I had one question. If can we use before transplant, if patient is a relapsed case of Hodgkin lymphoma and CD30 positive, can we use in the second line before going for transplant?
Absolutely, yes, Dr. Abhishek. I think we have had a couple of discussions also.
Along with bendamustine. But this is a phase 2 trial actually. There's no clear cut. It's not in the guidelines actually, but I think this will be very much effective before going for transplant.
So we have used, I would say, like not less than 10 patients, we have used brentuximab as a second line treatment in patients who are relapsed refractory. We have used it in combination with bendamustine. We have used it in combination with nivolumab. We have used it in combination with pembro also. And I would say the regimen works. At least to get the patients into remission. At 2 cycles, these patients get into remission, can very easily progress to sort of autologous transplant, who otherwise we know that they have to be exposed to multiple lines of chemotherapy, and then they can proceed to transplant. There can be a problem of autologous stem cell harvest failure. Those are the additional toxicities that can be seen. So these are the toxicities, but I think we have used brentuximab in sort of significant number of patients, and the responses have been good so far with us. So again, whether there have been a lot of debate whether pembrolizumab and sort of nivolumab in different combinations with chemotherapy regimen without CD30 molecule can be as effective. But yes, these are all speculations. I think so far there is no randomized trial to compare brentuximab with one of the PD-L1 inhibitors. Until that data comes up, I think a combination of CD30 and PD-L1 is a good sort of regimen to induce remission in these type of patients.
So combination of CD30 and PD-L1 or combination of chemotherapy and CD30, which one is more effective according to you?
So that is what I'm telling.
Cost,
there is no
cost
trial.
is not an issue. Cost is not an issue. PD-L1 with CD30 or CD30 with bendamustine, which one will be more effective? Any personal practical experience?
See, again, I will tell you, till PD-L1 was not available, till that time we had been using brentuximab with chemotherapy, essentially with bendamustine or other chemotherapy regimens. But after the availability of sort of PD-L1, we have used nivolumab and brentuximab, and that data is equivocal. I have not seen a trial where bendamustine brentuximab has been randomized to be compared with PD-L1 CD30. That data I have not seen, but at least efficacy wise, both sort of regimens are effective and good efficacy.
And what's your take on post autologous transplant in this Athera trial?
It
improves the PFS only in high risk cases, but not the. So should we go for it? Like there is a cost issue involved in that.
So again, that is what I was going to tell. Till Takeda was sort of compassionate enough to provide compassionate access to brentuximab, we had a couple of patients who were on maintenance, who still are on maintenance treatment with brentuximab. Yes, you are right in saying that PFS benefit alone is there. There is no documented OS benefit. But at the same time, I think that those patients who can be prolonged, can have a prolonged sort of disease-free period, for them also it is beneficial. Again, in the current clinical context where it is available only on payment, of course, yes, that calls for a discussion. But again, like we are not the only people, or we are not the only factors to take a decision on the patient's behalf. Like the discussions have to take place with the family. They have to be explained that this can prolong the control of the disease or prolong the duration of the disease control, but it may not result in a prolonged survival benefit. But after explaining to that, if the patients agree, accept, and give consent to, in that case only, I think this type of consolidation can be tried.
And you have seen sustained remissions also, even after stopping brentuximab, like post autologous transplant. So
See, I will
there
share
is
experience. Two patients, one Hodgkin's lymphoma, one peripheral T cell lymphoma, post autologous transplant. Both received 16 doses of brentuximab. One patient of T cell lymphoma had a relapse 4 months after stopping brentuximab. Another patient of Hodgkin's lymphoma, 10 months after stopping brentuximab, they relapsed. So I don't know how to correlate this, whether it is the brentuximab that kept them under remission, or it was just that incidental thing that we stopped and after that it relapsed. It anyways had to relapse. I don't have an answer to that, but yes, it has got a positive impact in terms of prolonging the progression-free survival.
thank you, sir. Thank you for the wonderful sharing of your wonderful
Thank you so much,
experience.
Dr. Abhishek. Thank you so much.
So I request Dr. Abhishek sir for the giving the closing remarks.
Yeah. Thank you all, the faculty who were present there and who enlightened us with their valuable inputs into the latest updates, including the breast and the colon, and finally the interesting hematology updates. And I'm glad that we learned a lot and we can take back home from these updates and put it in our practice. And I hope it was a valuable interactive session to all the attendees and the faculty there. Thanks for your participation. Thank you and good night.
Good night, everyone.